who is going to be leading the discussion with our panel. So without further ado, Dr. Johnson.
I got caught in a rookie Zoom move where I thought I wasn't going to be showing my untucked shirt. So I apologize for the untucked shirt. Well, we have three physicians with us today that have distinguished themselves in my mind as some of the best physicians that I know of. You know, I've had patients that we've had mutual patients with each of you, and feel just really good about the care that you give patients. But also, you have distinguished yourselves in the sense that you have also been able to figure out or cared enough about patients to figure out how to provide healthcare outside of the insurance-based sick care system. And so I'd love to give like a full bio on each of you and go through all of your accomplishments, but we don't have time for that because you guys have done too much stuff. So I'll just kind of introduce, this is Dr. Jordan Glenn, who is a general surgeon. This is Dr. Jeremy Bramwell, who is a primary care specialist here, a family medicine doc. This is Dr. Nathan Moore, who is orthopedic surgeon. And so we're going to just be talking about how healthcare can be done, is being done outside of the bounds of insurance-based models. And so I had a question for you, Dr. Moore, to start.
Yeah.
It wasn't too long ago that we had, I had a patient who needed a total knee surgery. He'd known he needed a total knee surgery for several years, but he didn't have regular insurance and just wasn't sure how he was going to get it paid for. And I referred him to you, and you were able to do a total knee for him at a price that was transparent, discussed up front, and this patient of mine had a wonderful experience with that, and was able to get a needed service that would have been really difficult for him to get otherwise if there wasn't somebody who was able to do this outside of an insurance-based model. And I don't know if you know the case that I'm talking about, the most recent one we had, but I wanted to ask you first, were your services valued appropriately in that interaction?
Yeah, I don't think it comes with any surprise that I feel like when people come for free market care, I feel like my services are valued way better and way more than they would be through an insurance model, because insurance tries to find any and every excuse to devalue our work. It's been astonishing that over the course of my relatively a young career, I guess, if you want to call it that. I've been in practice 8 years, but that year in, year out reimbursement from insurance just keeps dropping, and cost of doing care, providing care continues to go up, and of course inflation, things like that. So, I mean, when we can lay out a nice, what I believe to be a fair price, it's transparent with people, and they can say, hey, this is something that I can afford and we can do. Obviously, you need to have partners that are willing to do this with you, because I can provide all the care I want, but I can't do it in my backyard. I can't do it in my living room.
Right. Or you shouldn't.
Yeah. But yeah, so really, I do think it's been valued well, which is the good thing.
Awesome. And if when we get to a point where there are streams of these types of patients coming in, how does that affect a practice like yours to have just a constant stream of patients who have a transparent pricing that pay up front for surgery? Honestly,
it would alleviate a lot of the concerns that we have through the regular insurance model, which is, are we going to see this money that we're for the work we're doing?
Yeah,
I mean, the amount of money that when I look back through the eyes of my billers and look back and see the amount of money of work that I've actually already done. And it hasn't either hasn't been paid at this point or is still waiting to be paid for whatever reason. It definitely alleviates a lot of stress from a practitioner perspective. But I think and so that's good. You want your practitioner to be less stressed and less worried about, how things are going to be paid. And your service is valued. But I think it allows for, better care. I think in essence, we don't have to jump through hoops to get to, hoops that insurance has set forth to get to the treatment that the patient actually needs.
yeah, that was gonna be my next question is how it affects the care. And I'm glad to hear that you feel like it enables you to give better care, at least in the circumstances that we've seen.
I mean, 60% of my practice, sorry, I don't want to take any more time, but it's probably maybe close to 70% of my practice is non-operative care of orthopedic issues. And then 30 to 40% is surgery, which is probably a little bit different from maybe in comparison to general surgery. A lot of what I do is non-operative. And so having to kind of like jump through X number of hoops to get to what we need to do to help people is annoying in a lot of ways. And it would be better if we could be a little bit more direct. So
Awesome. Thanks so much. So now, Dr. Glenn, you've done a lot of cases in this sort of transparent model. And I remember some early cases that we worked on together that it wasn't clear that all the systems were set up and ready to go for this. Can you tell me just a little bit about what it took for your operation to be able to handle so smoothly all of these cases outside of the insurance-based model?
Yeah, well, unfortunately, the way things have been set up and depending on where you're doing surgery and stuff, it's all geared towards insurance benefits.
Yeah.
And someone walks through the door, our goal, first of all, and most offices' goal is to confirm benefits. And then before you do anything else, everyone wants to make sure they're getting paid. So I think patients were getting questions about, how I'll, oh wait, you're self-pay or cash pay, and but so getting my own office set up to take care of that is not a big deal. I have a office manager who was ready to play ball and really excited about it.
Yeah.
I think we might have had some patients who got some balance bills early on from anesthesia. And that was just a matter of getting with the right group that also was willing to just have a transparent fee schedule. And then the surgery center, once again, same thing. And the kind of to go back to what you said, I think insurance is all based on codes. Obviously, we know that, and it's somewhere years ago thought that was a great way to just sort of quantify, oh, you did this, that's such and such a code. But what it really does is it commoditizes what we do, and it allows them to just kind of bundle and package what we do, and it dehumanizes, I think, what we do as physicians, frankly. So this allows us to kind of step outside of that model and just be transparent and be, I think patients are already going through this sort of often devastating and very high stress situation where they're going to need to, have general anesthesia and undergo a dangerous procedure potentially. So to add the stress of like, I'm going to get a balance bill, or I'm going to get, this and this, extra bills or unforeseen expenses with it is just really kind of, it's mean to put people through that. It really is. So, but yeah.
So you talk about dehumanizing of healthcare by the way that the codes are set up. And the first thing that came to my mind is that I have patients that I've sent to you, and I've had patients who have had surgeries done by other surgeons. And in most cases, the thing that determines how much you get paid is just whatever the insurance company says is the rate, not who's the better surgeon or who has, who's most qualified to do it. Do you have thoughts about how that affects the fact that there's no connection with value or even perceived value between the cost of the price of the surgery and the quality of the surgery? How do you think that affects quality in general?
Well, no, that all surgeons are equally good.
Oh, all surgeons are the same.
Did you know that?
All surgeons are in the top 10% of surgeons.
It's just all the same all the way across the board. No, that's clearly not how it works, but for a given procedure, all surgeons basically make the same. So it does not allow for that. Now, and as our costs continue to go up with inflation and our reimbursements continue to go down year after year, the one who really suffers is the patient, because we are under constant pressure to just get more done in less time, because our cases are just, it's a commodity, right?
Right.
It's not, so surgeons in general are just motivated to get more patients through the door, through the hospital. And, a lot of, everyone knows this, a lot of times you're not even going to see a doctor other than maybe on surgery day. A lot of times you're just dealing with mid-levels and things like that. So not necessarily that that's bad, but that's often the way it's done. So we definitely need to step outside of that model, and now that we have patients through health sharing plans or cash pay, who are willing and ready to kind of seek the best quality care, no matter whether they're on the preferred, Aetna preferred list or whatever it is, then that's only going to improve the situation for everybody.
Cool. Well, we talked a little bit about the kind of care that can be provided through, changing the business model. I'm most familiar with Dr. Bramwell and the kind of care that he gives, and frankly, I'm just super proud of being associated with him. This is a weird time to get emotional. It's so important to me that these patients get taken care of in a way that that values each individual. And Dr. Bramwell has, he joined our practice years ago, and it means so much to me to have the knowledge that the patients that we take care of get the kind of care that Dr. Bramwell provides. So I'm interested in what experiences you've had where you felt like you were empowered or able to give a different level of care, a different kind of care than you were when you were working in, the sick care system.
It's a great question. It's like there's so many examples and opportunities that things are different. I spent 5 years in the sick care insurance-based model, and now 3 years in direct primary care, where a lot of those barriers are removed, and it's literally night and day difference in what I can do for a patient, or even how I think about a patient. Days were so filled before with endless, nonstop patients, multiple squeeze-in patients, and then an endless list of tasks. And could I even think about a patient that wasn't on the list in front of me and spend time to like, oh, I just saw that person 2 days ago. I need to check in on that person. That wasn't a possibility with the time constraints having before. And when we have an acute need that comes in and be able to, one, see them same day or earliest next day, and sometimes even an encounter after hours, to be able to have that continuity of care of checking in on them, seeing the progress and the hoops that can be saved the patient and the end result is just amazing to see. So, one example is a patient that called in with concern for kidney stone after hours, and office was closed. We didn't have everything we could do, but able to get a CT, ordered stat, get a result back, able to diagnose that, yes, indeed, this was a kidney stone. We didn't have to rule out some other things, able to get stat labs as well, or at least that next morning, able to provide comfort and medication without him ever having to go into ER, and able to help him, pass through that, that painful situation, with frequent contact from, not just myself, but the office reaching out. And that's not something he would have gotten anywhere else. He would have been through the ER, kind of jumped through multiple hoops and eventually gotten some, some help down the road, but saved the patient who had no insurance, thousands of dollars, and able to be in contact with us. And every time it's like, I'm just so grateful, for that time you helped me out every time I talk to him. So that's really cool to see. An example from this week, had a patient that called in with like excruciating knee pain overnight. And it was early in the morning. And instead of when I was on call before, it was, you got two options: call the office in the morning or you go to the ER. There wasn't much more. I was able to have a half-hour conversation with him, able to actually, based off of the mechanism of injury, what he was experiencing, his lack of weight bearing, say, you know what, we need to get an MRI. You have a concern, you have an acute tear. Didn't have to jump through any hoops, able to get an MRI that day, a result the next day. And he had already seen an orthopedic surgeon in the past, able to get him in with that orthopedic surgeon within 2 days and just bypass ER and give him, a pain management, for that acute pain and a plan. I didn't even see him in office, and I didn't even able to get an evaluation on the knee, but, just based off of that, experience, able to bypass a whole bunch of hoops there. So those are a couple like specific examples, but just in general, I've never had the thought of, okay, I got to think of who's the next patient before in the sick care system. Now they're pretty well, they don't have a lot of issues. Okay, what are your health goals? And I get to ask that, and I get to follow up with them. Like, okay, how do we help you get to be healthier? Not just get through sickness. And that is a constant thing, able to discuss and have the time to get into like the grid of lifestyle changes and help them, promote a healthier lifestyle and make changes. And an example, we had a patient came in, called in, he was concerned about his blood sugars, was not diabetic, thought something might be off, got a glucometer at home, had a blood sugar of 380. Like, whoa, normally would be in the ER for that. We were able to get him on insulin that day, able to talk about lifestyle changes and 3 appointments over the next 3 weeks, and got him from an A1C of 13 down to 7 and off of insulin within 5 weeks. Just because of what we could do. And the amount of accessibility he had to contact of like, here's my sugars, and we would make an adjustment and lower his insulin and change this with his diet. Wouldn't have happened anywhere else like that.
I love it. And I have, information about lots of examples of ways that you've helped people. But perhaps more meaningful to me is just hearing how people have felt when they were in your office. And actually, I can say the same thing about all 3 of you. All of you, I've had patients come back to me and say, I felt like they cared about me. I felt like they were engaged with me. And part of that's just who you are as people. And you do that in any, in any business model. But I do think that there's a significant difference in how empowered we are to show that kind of care for people when we're not operating off of some arbitrary constriction that is, set up by somebody else who determines how much this encounter is worth. So I'm just grateful to all of you for the kind of care that you guys give. You mentioned a patient that doesn't have insurance and this kidney stone, and I actually thought you were going to share a different story about a kidney stone who was a very similar story. It was a Saturday morning, and we were able to get imaging that Saturday morning. We were able to determine the size of the kidney stone, so we knew that they didn't need to go to the hospital. They didn't need lithotripsy or anything to pass this thing. It's just medication and pain relief, reassurance. But that particular patient was on an employer plan. So their employer was paying for their health care. So they would have gotten, care in the emergency room, and it would have worked out just fine for them. Although they preferred the way that we were able to take care of it, not waiting in the emergency room, not paying a $500 copay. But I wanted to just bring that up because there's these two different stories that we're telling, and everybody's alluded to that there are a couple main different ways that we can provide healthcare directly or outside of the insurance-based system. And one of them is like the total knee case that you did. That was the patient paying out of their own pocket. And they saved up to pay for that surgery. And then another case is when the employer is paying for it. And so I wanted to talk a little bit about how big the opportunity is here. We mentioned that potentially there's streams of people coming in outside of the insurance pay system. Do any of the three of you have a real feel for how many people are out there that this might work for?
I can speak to that. Sure. Well, I think the first time you guys sent me a patient, this was maybe 5 or 6 years ago. Patient had a health share plan, and I had no idea what they were talking about. But the patient reassured us that, don't worry, you're going to get paid. And it was actually surgery on their daughter, and so we were able to take care of that. And that was my first introduction to health share. Fast forward to the last year, my son was diagnosed with an abdominal tumor, Burkitt's lymphoma. We've been on a health sharing plan. Myself, we dumped our overpriced insurance plan a couple of years ago. And other than the initial $1,000 or whatever it was, every expense has been covered, and he's gotten the best quality care. Yeah, all at cash pay rates. So, and mind you, that's all by in the hospital and in the the networks and stuff of healthcare that exists here. But I talk to patients almost every day. They say, oh, well, doc, I want to get this surgery done, but I'm going to see what else I have to get done this year. Maybe when my deductible's paid up, or, well, I want to get these veins fixed, but let's just maybe towards the end of the year, you know what I mean? And why should people be making healthcare decisions like that? It's completely backwards. It's really tail wagging the dog instead of them, hey, you need this, let's get this done. Let's get ahead of this before you develop issues and stuff. So, no, it's definitely the way to go. Now, more and more people every day are on these plans or making these kind of decisions or having just circumventing the traditional. Yeah, because unless they're in a big corporation or they're part of, a government plan or something, that it's just completely unaffordable to have traditional insurance this way. It gets them so little and it costs so much. People just are, as soon as they find these other options, they're really happy to do them. And it's better for them, it's better for us.
Yeah, I don't know the exact statistic, but I heard the number 40 million people in the US using a health share program right now. So if that's totally wrong, then, put it in the comments and let me know, but that's the number I heard. And I know, I know that there are many millions of people who use these health share plans. And another thing we won't have time to get into much today is that in the city of Phoenix, in the Phoenix metro area, there's 4 million people. Approximately half of those people are covered by an employer plan. And about half of those are a self-funded employer plan, which means that the company is paying for these expenses out of pocket, just like in the case of the kidney stone that we were able to save, thousands of dollars from going into the hospital. That money was going to come right out of the employer's pocket, and that in turn really comes out of the money that's used to compensate the employees too. So it's really the employees are paying for these higher costs of care that are unnecessary, and maybe I'll just clarify right here. One of the ways that these costs of care can be unnecessary is not that we're going to pay these surgeons less money to do their job. In fact, I want to see surgeons get paid well enough that they're motivated to pick up the phone as soon as we call. Where the opportunity is not by discounting the price of care, but by getting surgery done or other procedures done in the appropriate environment, which means that we can do it at a surgery center for a total cost of $2,000 facility fee, as opposed to doing it in a hospital with a $30,000 facility fee. And all of that difference between $2,000 and $30,000 has no benefit to the patient or to the employer. So sorry to go off on that tangent. I just want to make it clear, we're not talking about trying to get discounted rates and trying to get doctors to work for less money. Doctors represent less than 10% of the total healthcare spend. So it's not about giving them less money. It's about making sure that we do the right care at the right time and in the right place. We have some questions from the audience.
This says Will Guy has a question. Like, in your experience, how often are you finding your cash prices need to be altered? And a follow-up to that, if you were to post your cash prices on your website, would it affect the insurance contracts since you're kind of all living in both sides?
So I'm going to repeat the question just to make sure that it comes through the microphone. The question, I believe, was how often do you need to alter your cash prices, and do you have concerns about publicizing your prices as it might relate to contracts with insurance companies?
I could say that sometimes, when costs of equipment and or implants or things like that change, and they have, then that pushes us to rethink our costs as far as delivering care. So that's one. And how often, I'll be honest, it really isn't that often, but it has been more recent with all the different changes as far as like supply chain issues we've had and things of that. We've had some implant companies come back and say, we just can't give it to you for this price anymore.
Yeah.
As far as like office visits and things of that nature, again, you're going to find that I think physicians, surgeons, however you want to look at it, we're not really good at keeping track of how our cost of things that continues to go up, and so maybe we need to look at this more often as far as like checking on our prices and stuff. But I think there are definitely things that kind of like push us into that direction, but it's definitely not very often. I think demand. I think the partner that you're working with can alter that as well. And kind of back to some of the other discussion, you know, but related, is you really do need to have a facility and or, you know, somebody to partner with where you can provide this care. Particularly surgery centers and often from a surgery perspective, and or, you know, a clinic space that can facilitate some of these smaller procedures and stuff.
So, you know, as it is right now, at least for me, yeah, you're right. My practice is hybrid. It's partly with insurance, and then it's actually a fairly small part of it is outside the insurance system. So we have to operate in that world. The way the contracts are generally written is that I can't make a patient pay more than the contracted rate. But if they're not on that plan, like they don't have, the insurance can't say I can never offer that service for a different price, you know, and advertised or not, generally their prices are always going to be lower, you know, because they're trying to gouge us basically. I shouldn't use the word gouge, but they're trying to get good deals off of us. So no, as long as we don't make a patient who is on like something that we have a contract with pay a different price than the contracted rate, then we're safe. It shouldn't be an issue. Now, in terms of raising costs, I think in general that doesn't really need to be done very often, because you know, as long as we stay above, you know, Medicare rates and things like that, you know, which isn't very hard, then we'll be fine. But I haven't had that issue really.
Awesome. Is there anybody else in the audience?
So I have a question. Have y'all, especially with the snowbirds? So I'm a friend of mine, he's from Canada. So do y'all do any business with Canadians?
That's where a lot of what I've done has started.
The hips and knees.
With the Canadians, yeah. And they come in, they're like, we have saved money our whole life, and this is a business expense, or this is just a lifestyle expense. And, you know, we're willing to pay the price instead of wait. Initially it was 2 years, for a joint replacement, you're on a 2-year wait list. COVID hit, it bumped to 4 years if you're not considered emergent or urgent. And so a lot of people were like, I'm not waiting 4 years to get my joint replacement done and go into the queue. And so that's a big part of what has pushed me into more, you know, working more with transparent pricing and just upfront pricing as far as like cash type, or we actually have gone ahead and with 1 or 2, I believe, of the health share plans, we've actually created a contract with them. This is our contractual price for your patients. So it's not like we're creating the wheel every time they come in. Not only that, but we've tried to get on their preferred list to send their patients to us, or like recommend that their patients come to us. I don't know how often that has really helped, but we do feel like that it's a good thing.
And this guy that I know, he played hockey, and so he was putting together a bunch of doctors and hospitals that when people came from Canada, they could come in, they would have everything already set up. And you know, I hadn't spoken with him for a while with the home health office and private duty that we do. We were sitting down talking about it, but with COVID, it kind of messed up a lot. But I had spoken with him, it's been a while, but looking to do that again. But I know we had some people he were working with and trying, which is certainly good, because I think that was, you know, it was great sitting, working up with the physicians, but it's the surgery center getting them to negotiate better prices.
And we also still try to do, like, there's a lot that goes into this whole process for our travelers, not just Canadians, but I have a lot of people coming in from Alaska, New Mexico, Wyoming, Colorado. They see what we do, what I do, and what our team can provide. And so they want to come here for that type of experience. So we've even gone as far as talking to local hotels. We try to keep a list of places people can stay. Obviously, a lot of people are like, well, I'm going to stay where I want to stay and I'm going to find it myself. But we do try to keep that list of, hey, these are the things you need to consider when you're coming and traveling. And it works out really well. I mean, knock on wood, you know, we have done really, really well with our travelers and we don't require them to stay for an extended period of time. You can come and have a total knee or a total hip replacement, and assuming everything goes really well, you can be home in a week.
We were working with the ortho on the west side and he had bundled. So because they didn't have insurance, he would do the hips and knees. And then we would go to wherever it was to do the therapy, you know, the next morning or in some instances that afternoon, once they got back to the hotel, we were there. Just making sure they were safe, and we probably seen him 3 times, but it was one bundle twice. And so they paid that way, they weren't being nickel and dime. He had it all set up and then they paid us out of that, so.
Great, that's ideal. Collaborating with other healthcare providers, yes, is ideal for sure.
So I have a question, for each of you, actually, if you just answer one at a time here. You know, we've sent this message out to physicians in the community, and we're going to be sharing it more with physicians in the community. So I'd like to hear just what would you say to your colleagues that have not, you know, been able to yet experience operating outside of the regular insurance-based system? What would you tell them about the opportunities here for giving better care or having greater satisfaction in your work?
Well, I would just tell them that, you know, it's a great opportunity. It's a growing opportunity. It allows them to just be kind of have less kind of those independent or, you know, middleman type worries. You're going to just have happier patients, you know, and which is, you know, I'm the same. I'm just a rock. I'm the same all the time, but my patients are happier. That's definitely makes it easier to work with them. And, if they're less stressed out, then it makes my staff happier, and then everyone's happy.
Yeah, absolutely.
From a primary care standpoint, I mean, I would say it is so much better on the other side. You know, going into primary care, I had these kind of like ideals and this like relationship that I wanted to have with my patients, why I chose that. Well, I was interested in other specialties and stuff, but I'm like, okay, I'm choosing this. I want to do this. And by the end of the 4th year out of residency into practice, I'm like, those ideals are all just destroyed, right? In the sick care system, I'm like, system wants me to be just I can't practice to my scope of practice. I can't care for the patients I want to. They want me to become just a referralologist, right? And not practice the way that reason I went into primary care. And it's totally changed that. So, you know, I went from being burnt out and depressed to like loving what I do again. And, you know, I can give 100 different examples, but it's been life-changing to be able to do that and get back to why I went into medicine and those roots.
Brian,
Yeah,
can
Tim.
you expand on, you said scope of services. Tell people what the scope of services that you do cover that they may not think of. I would go to my physician for that. I mean, obviously, that's the wrong way to say that, but you get what I'm saying.
Yeah, no, we'll get all the time. We'll get people call like, hey, I need a referral to a dermatologist. We're like, okay, well, what's going on? Can we help out? And we can diagnose and remove skin cancer depending on location and degree of difficulty, but we can do things like that. We can take care of a lot of those other specialty services that are really, most of those specialists they'd rather have us do them as well in primary care. The system just doesn't allow for that. So
You guys do basic meds in your office too, right? You still do
correct.
that?
Yeah. I mean, maybe Dr. Glenn might not be super happy about or hearing about this one. We had a tag team on a pilonidal cyst that was pretty extensive. I don't know anyone else who might have done that outside of an OR. And it turned, the patient had no cash and, no insurance, and it was like a family member that had to pay for it. And it was like, we were able to do this and wound care for 6 weeks on it that just wouldn't have happened anywhere else.
We rocked that pilonidal cyst.
That was
Good job.
great.
You can have.
So those are some examples, but a lot of times they feel like, hey, we need, my primary care is, I'm there, like they're there for if I'm sick and maybe some basic stuff. Other thing is what we do is a ton of taking care of, if you feel like you need to go to the ER and urgent care, we're available. We'll meet people at the office, sew you up from a laceration, save you ER visits. Most of all that goes to an urgent care does not need to go to an urgent care if you have a primary care physician that can take care of it. So we definitely can help out from that standpoint. And I honestly, probably 70+% that goes to the ER probably does not need to go to the ER at that time. It's because they couldn't get into their doctor in a timely fashion. So there's another side as we can help out with a lot of acute situations.
Yeah, I've worked those ER shifts when 9 out of 10 of the people that came into the ER could have called me on the phone beforehand. I would have helped figure out why they didn't need to go to the ER. Dr. Moore, what do you have to say?
Yeah, regarding what I would tell other providers that aren't participating in this is I think it comes back to the patients, and their satisfaction. I mean, I think if you look at, the way medical care is kind of driven now, a lot of it is driven by patient reviews, patient perception as to their experience. And that model of getting as many people in and through your door as fast as possible to make the money you need to make to feed the beast that you created, I actually got away from that. I didn't want to be in that situation anymore in a big, large orthopedic practice. And so now people walk in, it's just less stressful. There's just, I don't have a ton of people in my waiting area. And the more that I can do this, cut out the middleman, the more that I can be that provider for people, whether it's through a private pay, health share, employer paid situation, the easier it is for me to then provide that same exact experience for people where it's less stress, less busy. And so I would tell people from just a patient satisfaction perspective, your reviews, whatever, if you want to think about reviews, that's a big deal. But then your patient's full-on experience would be much better.
Yeah, I've read some of your reviews actually, and that's one of the things that comes up. It's just the feeling in the office, not even just with you in the room, but the feeling coming in just feels like a less stressed environment. So,
And then also how handsome you are too.
I was
Not quite as handsome as you.
I was going to make a comment about how these panelists were not picked solely on their looks, but we're really grateful. We're really grateful for all three of you for coming in today. Looks like we have.
Yeah, there's one more question
One more
here,
question.
and it's, you talked a little bit about how many people are in self-insured plans, and a lot of times those they're administered through a broker. And what are you guys doing with your practices to make yourselves more visible to those that want to buy through that brokerage channel? Because these people are charged with keeping costs low for those employers, and obviously you're offering a very high value, low cost service. So what are you doing to make yourselves more visible to those brokers that are administering these self-insured plans?
I know I need to do more.
We could always do more. The sad reality is that we're just doctors. We're not marketing people, and stuff like that. There's a constant, push to better what we have out there, websites, et cetera.
I think collaborating with those
You guys.
with you guys is really key. And so the more we can collaborate and the more we can, get on, whether it be some form of there's just not enough knowledge out there, not enough understanding out there that this is possible. You know, and so it just needs to be shared in whatever way possible. So I've been, I do a lot of, for a while I was doing a ton of talks at physical therapy locations, just to try and kind of, get that more of that information out there that we're here to help other physicians, DPCs. So.
Awesome. Well, and that is really the point of these meetings, actually, is to help connect the buyers of healthcare with the sellers of healthcare. And, though as physicians, we don't usually talk about ourselves as selling something. I mean, we have a service to provide, and people need to purchase it in order to take advantage of it. And so that is a job that we're trying to accomplish here today, is to just break down the barriers between those who are looking for the kind of care you can provide and the other physicians out there that want to provide high quality care and have good job satisfaction while doing it. So thank you so much for spending the time with us, and especially for the care that you give patients. We appreciate you guys.
Thank you.
And thanks everybody for tuning in today, and for those of you who are here in person, have a wonderful day.
Appreciate it.
Great.
Thanks. So can I just ask you real quick who everybody is here that's actually like